Yourselves for a fantastic panel presentation. As I've been saying, we've been moving from the micro to the macro, and we've got three presenters this afternoon who operate in very large systems. We're going to start with Sarah Church, who runs probably one of the largest addiction treatment systems in the country, I would imagine. And she's going to have all kinds of interesting tales about her collaboration with government agencies and hospital administrators and OASAS. And so we're really proud to have Sarah on our committee and proud to have someone of her stature able to present to you today. So I give you Sarah Church.
Thank you, Richard. I appreciate that. So I had planned to start my talk by apologizing to you all because I'm going to be talking about some things. The beginning of my talk is going to be kind of boring. But I think I need to do this part to get to the sort of more exciting stuff later in my talk. But when I heard Rebecca's talk this morning, when she talked about boredom and the countertransference with boredom, I thought, oh, so then I'm just trying to put you all to sleep so you don't have to listen to me? Or, I wasn't really sure what I was doing. But in any case, I'm going to go through I want to talk about a broader context of collaboration because there is a lot going on in the world right now, especially in mental health and in substance abuse, where there's a lot of electronic data collaboration, where data is being transferred between programs, it's being transferred between hospitals in a lot of different ways. And I want to talk about that a little bit in terms of substance abuse and sort of the implications of all of that and how it affects our work. And then I'm going to talk about some things that may be a little controversial. And I'm curious, I think this is a really good forum to do that. And we're going to have a little time to talk later. And I want to get people's input and impressions about some of the things that are going on. Because I had initially one idea about the way things should work. And over the years that I've worked with this population, I've come to think something very different. And I'm going to go through that with you. So let's get to it. Okay, so there's a changing landscape, right? So historically, mental health and substance abuse providers have painstakingly have provided or tried to protect privacy and confidentiality of their patients. And I don't think that's really changed, but there's this national effort to share healthcare information. And the reason behind that is they want to improve care and reduce costs, right? And you're all hearing about this. And there's the National Health Information Network, which provides a common platform for nationwide health information exchange across diverse entities. And it provides standards for federal agencies, healthcare providers, health information exchanges, and consumers to securely exchange data, both at national and local level. And it's basically, you're hearing a lot about the HITECH Act, right? So there's a lot of pressure. President Obama's put a lot of funds into this, and people are getting meaningful use dollars to get on EHRs. And it's sort of, if you're working in a hospital setting or if you're working in an agency, you're probably working on an EHR now, right? So there's this electronic collaboration and data sharing. I think, if you're on paper now, it's unlikely because most hospitals are really moving to electronic paper or electronic records, right? And then you've got the electronic record at your program, and hospitals are now sharing that data into health information exchanges, or RIOs, the Regional Health Information Organizations. Like I work at Montefiore, they share their information with the Bronx RIO. So all of this data is getting sort of sucked into a database somewhere in the cloud or somewhere on a server. And if a patient consents, then you can access that information, right? And people don't really realize that the data is just being collected and put somewhere regardless of consent. And then if the patient consents, you can access it, right? So there's health homes, and there are a lot of case managers coming into play with managed care. and they share information electronically too. So there's Medicaid claims data, there's Psyches, there's a lot of different databases. You know, HRA has New York City Way. There's all these different electronic systems where they're managing and tracking the care of clients, and people are sharing care plans and sharing information, hopefully for to better the patient's treatment. So the key components to health IT infrastructure are the EHR, the electronic health record, right? And then there's also personal health records, and people don't know as much about these, but this is not like a portal for sharing information with their provider, but more when a patient wants to sort of organize their own electronic health information for themselves. And they can share it or not if they don't want to. And then there's the health information exchanges, which we talked about, that facilitate communication among different entities. And then the regional health information organization. So this is a broad, multiple providers like Barnabas and Bronx Lab and Montefiore all work together for the Bronx Rio. They pool their data together, and then when a patient touches any one of those systems, there are messages that get sent out to anybody who has that provider in their network. So if one of our patients gets hospitalized at Bronx Lab, we get a Rio alert, so we know. And that, you know, supposedly helps coordination of care. So the benefits, why are we doing this? What are the benefits of this? You know, the idea behind it is sharing this medical information to improve the speed, the quality, the safety, and cost of patient care, to avoid readmissions, to avoid medication errors, to improve diagnoses, and to decrease duplicate testing, right? So try to bring that down costs and improve care. So for folks who treat addiction, there's some special rules, right? So we all know that 42 CFR Part 2 is a federal regulation that provides special protection for addiction information, right? And it was initially enacted in 1987 to try to combat some of the discrimination that patients can feel, and to make them feel safe in seeking treatment, that their data won't be shared, right? So to try to make it easier for people to come into treatment. And to this day, we still have this regulation in place. And that regulation makes it difficult to share information in substance abuse, because the electronic health records don't have the capability to sort of segregate or sift through the data and keep that separate. So there are certain health information exchanges that can do that, but most can't, right? So, and if you don't comply with 42 CFR, then you can be fined, right? So it's $500 for the first case in which you don't comply, and then it could be up to $5,000 for every one subsequently. And if you mistakenly share a huge file of patient data, this could be extremely expensive for an institution, right? So people are very wary of making mistakes and having any kind of data breach. So what are the consequences of this? So most addiction and behavioral health treatment information is maintained in a separate database. It's not on the main hospital EHR. It's segregated in a separate system, right? And this is being done, you know, to protect patients' rights. But I've come to realize that it also adds stigma to our patients and to what's going on. And it sort of, it makes our data secret. It makes our data separate than everybody else's data. So in our OTT, we don't share information into the RIO, but we can get information from the RIO. And, you know, I've started to think, you know, by stating that this information has to be protected more than other medical information, because medical information is already protected, this is like an extra level of protection. What are we really saying, you know? On one hand, we're working so hard to teach healthcare providers, and I've done this, I've done lectures, I've done talks, I've gone to people's offices to talk to them about, you know, treatment, and, you know, we're saying to them, you know, this is just another medical disorder. This should be treated like any other medical disorder. But then at the same time, we're saying, well, this data has to be treated differently. It's separate, right? So I oversee a large opioid treatment program in the Bronx, and I think I'm going to go out on a limb here and say that opioid treatment is probably one of the most stigmatized treatments out there, right? And we're particularly concerned with confidentiality and privacy, and we think about it a lot. And in the past 2 years, through my treatment program, we've developed 2 films. One was like a quick 6-minute film that was done by some peers, some patients in our program, to talk about a peer program that runs called MARS, the Medication Assisted Recovery Service. And after they did that program, I was really hesitant to let them do the film because it made me really nervous that patients would maybe participate in the film, but they later regret it because people would learn that they were in methadone treatment, or there would be some kind of negative consequences, or they'd regret having shared that information. But after the film came out, it was so powerful and so amazing, and people really felt the patients who didn't participate in the film came to me and said, why did you, because we went to the patients, we said to them, listen, if you're going to participate in this film, you have to sign this consent, and you have to understand anybody could find out that you're a methadone patient, anyone could know, this could go anywhere, we don't know exactly where this film is going to end up, it's going to be on the internet, that kind of thing. So you really have to think carefully about whether you want to share that with people before you decide to be in the film. And so a lot of patients didn't participate because they were afraid of that. And those who didn't, some of them who didn't participate came to me later and said, why'd you scare me so much? I wish I'd been in the film. Like, I wish I'd been part of it. And then we ended up doing a longer film, a 70-minute full-length film about our Hep C program, which was also told the story of peer advocates who were in our program that shared their success stories. And again, I was worried about it, but in the end, it was very powerful, and it was really amazing to see our patients talk about their lives and share their stories on film. And the patients really found it cathartic and liberating and empowering to share their stories and say, I'm in recovery and I'm taking medication that supports my recovery. And having said that, their secret was out. There was no longer a secret, and it was really, I think, therapeutic for them. And their stories were so compelling, I think a lot of people's lives were changed by learning about their stories. So I sort of struggle with these two things of, and I'm not advocating, obviously, for sharing people's stories who don't consent or don't want to share their stories, but I think that in trying to move forward and trying to collaborate and trying to reduce stigma of our treatment and for our patients, that we need to think about how it's important to share the success stories and the positive stories that patients have to really change people's understanding. Because I think that the one of the problems we have in collaborating is that there's a lot of stigma around our treatment and around our patient population, and we need to find new ways of trying to change that. And it seems to me, as I've been working through this, that it's in people learning and meeting people who have been through addiction and have moved into recovery, that they understand that treatment works and that there is a lot of hope, and in that way we can combat stigma. Because you can tell people over and over that treatment works and treatment's effective, but when they meet people who've been through it and have succeeded, then I think they believe it a little bit more. So I think the faces and voices of recovery, I think, are very powerful, and those patients can serve as role models to encourage other patients to reduce the secrecy that's shrouded substance use and substance use treatment. And the idea, and I know that SAMHSA actually has been really shifting. They used to really hold very firmly to 42 CFR, but over the years I've seen on their website and through their documentation that they're really shifting towards moving away from that, and just wanting to use the protections that are there for all medical information. And I think that when medical professionals truly feel that addiction is just another medical issue, like any other medical issue, it will be much better for our patients. So I'm hoping that, we'll get there one day. So the questions that sort of came up for me, and hopefully now for you, is does this additional level of privacy, the 42 CFR, over and above other healthcare records, help patients by protecting them, or does it increase stigma and shame by keeping patients' records in separate databases and keeping their treatment isolated from the treatment of all the other folks in a large hospital system? Something, food for thought. That's everything I have.
Dr. Washton?
I'm here.
So let me put Sarah on the spot, since she's raised such a provocative question. and she is. You are the executive director of the Division of Substance Abuse at Montefiore, a gigantic healthcare system. You probably do have a boss, but if you didn't and you were in charge and you could push a button and get rid of 42 CFR so that addiction-related medical information was treated the same as any other medical information, would you push that button?
I would. I mean, I think it should be the same. I think that if we're trying to get to the place where we're saying addiction is the same as any other medical disorder, it should be treated the same. That the information should be treated the same. But I know that I'm probably in the minority thinking that. But I've thought a lot about it, and I think that it's a double standard, and we need to remove those double standards.
Thank you. It's a really interesting question with the history of anonymity with respect to addictions. What the sweet spot is right now. So thank you. So I'd like to introduce Dr. Arnold Washton, who, as Andrew mentioned, is one of the founding members and founding president of the Division on Addiction, and he's written a couple of seminal books in outpatient treatment of substance abuse, and he's going to be talking about where he's at and how he came to be there right now. Okay.
Well, that's a long story. I'll be brief. Thank you, and I really appreciate the opportunity to speak before this group. It's been a long time for me. It's good to be back. The theme of this conference is complexity, and a couple of speakers, Sarah just talked about it on a macro level, the issue of collaboration, integrating care, some of the obstacles to that. Joe, you mentioned it multiple times about the idea of, how great it is to see physicians and psychologists working together, having everything in one place, and that there's a kind of synergy to that. Traditionally, psychologists in private practice, we've worked alone. If we interface with psychiatrists, it's generally psychiatrists who have their own practice somewhere else in town. It can be difficult to find a psychiatrist who is like-minded, who you can work with smoothly. They say the same thing about us, I think. The care is always fractionated in one way or another because it's hard getting each other on the telephone. Even if you do get each other on the phone, you've got 20 seconds in order to say whatever you have to say, and the richness of what's going on clinically with the patient and the need for the collaborative effort can be given very short shrift. Now, we have all been talking for decades about the biopsychosocial model and that it makes sense to all of us, but rarely, if ever, do we actually get a chance to see it in practice because care does tend to be fractionated. And the discussions today about integrated care tend to be discussions on a macro level, that is, integrating primary health care and behavioral health care in large systems. Obamacare is pushing things in that direction, for better or worse, but we hear little, if anything, about it on a private practice level. In fact, when we think about integrated care, most people tend not to think about private practice. So I'm here today to talk to you about how we have operationalized the concept of a biopsychosocial approach and integrated care in a private practice setting where psychologists and physicians dance together. And it raised the question from the outset of would we be good dancing partners? And how could we make ourselves better dancing partners? So integrated care is especially relevant to the treatment of substance use disorders, as you know, because these disorders have complex etiology. They have to address multiple problem areas. There's an increasing prevalence of co-occurring psychological and psychiatric issues that travel along with substance use disorders. There are a whole host of medical problems secondary to chronic substance use and deficiencies in self-care on the part of the patient. It's not hard to see what the rationale is for integrating these services together in any clinical environment, certainly including private practice. And I would argue that the treatment of substance use disorders increasingly requires, and this is only going to continue, require closer and closer collaboration between psychologists and physicians. And reimbursement strategies are moving in that direction as well. I think it's going to get harder and harder to get reimbursed for psychological services that are not somehow integrated with medical and psychiatric services. There's also the fact that the combination of therapy and medication are often more effective than either one alone, and this is especially true for people who have co-occurring psychiatric issues. But it's also the case with the increasing armamentarium of pharmacologic treatments we have available now, that there are opportunities to increase clinical efficacy through combinations, creative use of pharmacotherapy and psychotherapy. And let's not forget, for many patients, and this is more true of people who are alcohol or opioid dependent, the medical detox is often the entry point of treatment and a prime opportunity for engagement using motivational techniques. Rarely do we think about detox on an outpatient basis. And so that's one of the services that we have developed, because many people who come to treatment, alcohol or opioid dependent, don't need to go into a hospital. Many of them don't need to go to rehab simply because they're physically dependent. Alcohol is more readily managed medically on an outpatient basis than I think most of you would think. Opioid withdrawal is never fatal, so we don't have to worry about that. Alcohol withdrawal rarely, if ever, fatal if it's managed appropriately. So we've developed outpatient detox as part of this continuum of care, and in-home detox, a mobile medical team that will go to the patient's home to ensure the safety of the detox process. So addiction exemplifies the interface, I think, between brain and behavior. There's probably no other disorder that so clearly demonstrates the interaction of brain and behavior. All psychoactive substances, by definition, chemically alter brain function. As psychologists, as Andrew has said many times, we treat people, not brains. But we can't ignore the important biological underpinnings of substance use disorders and the increasingly important role of medication in the treatment of those disorders. In fact, I would contend that as proponents of evidence-based care, which we, I think, all are, especially in our scientist-practitioner model, psychologists should not support the anti-medication bias of traditional treatment approaches. I think we do our patients a disservice. I think we do our profession a disservice by doing that. Yes, medication alone is not a complete treatment, but often a valuable component of an integrated approach. The effectiveness of medication, when indicated, is markedly enhanced by psychosocial interventions and vice versa. Psychologists have a very important role to play in helping patients who need pharmacotherapy accept the pharmacotherapy, an important role to play in helping them comply with prescribed medication regimens, and also to help patients deal with side effects without blowing out the treatment, without throwing the baby out with the bathwater. It's a mistake to think as non-physicians we don't have a role to play in the appropriate use of prescribed medication in the treatment of any disorder, but certainly in the case of addiction. Just look at this growing list of pharmacotherapies now, most of which are FDA approved, not all, which have shown some degree of efficacy. None of them are the magic bullet, of course. Buprenorphine is by far the most effective pharmacotherapy for opioid dependence to come along in decades, if not the most effective one that exists ever. Oral naltrexone for alcohol, for opioids, Vivitrol, the depot injection that lasts 30 days, and then anti-craving and anti-relapse drugs, the oldest being Antabuse, which you're all familiar with, which I think is grossly underutilized. Not to force people to be abstinent, but to help patients prevent impulsive, unplanned relapse. So Compass Health Group, which is an integrated practice of physicians, psychologists, so we're a group of physicians, psychiatrists, internists, and addiction medicine doctors, all practicing in one place, in the same office, passing each other in the hall all day long. emerged organically from a 12-year collaboration between myself and Glenn Brotman, MD, a psychiatrist, who I came to know when he was a resident and continued to collaborate with when he went into practice. We both had self-pay private practices in separate offices, just a few blocks apart on the west side of Manhattan, primarily high-functioning adults, many executives and professionals, and we cross-referred and co-managed care for substance use patients needing both psychotherapy and pharmacotherapy. So I was very lucky to find a psychiatrist who I could work with and work with well, and somebody who is flexible and open-minded and willing to be creative with pharmacotherapies. The patients appreciated and benefited from our close collaboration, but some mentioned the practical inconveniences of commuting between our offices, juggling multiple appointments, dealing with different office staffs and procedures and billing procedures and the like. And as the numbers grew, it became more difficult to maintain optimal coordination of care between us, even being only a few blocks from each other. So we said to each other, could we improve our effectiveness and the efficiencies by locating both practices in the same space? We could provide, hypothetically at least, a greater range and variety of services in one place. Could we create a continuum of private outpatient addiction care? Could we recruit other addiction specialists to join our team? So our mission at Compass Health Group has been to provide integrated addiction, psychiatric, and medical services in a private practice setting with a major emphasis on treating substance use disorders with or without coexisting, co-occurring psychological and or psychiatric conditions. Another mission of Compass Health Group is to provide to psychologists and other practitioners the needed services that you can't provide yourself. So psychologists send patients to Compass Health Group for medication consults, pharmacotherapy, outpatient detox, or groups, what have you, while the patient continues with the individual therapist. It has the appeal to the patients, at least, of one-stop shopping, and there are multiple synergies that are generated by having different specialists work together in the same place. We opened on February 1st, 2014, so we're only a year into this whole thing. We have a common administrative staff, same waiting room. To patients, it looks like one practice, but we are multiple practitioners functioning in the same space. We all share and we have access to the same database for scheduling, for patient records, so that everybody can find out what everybody is doing. The whole system is cloud-based. It's an internet-based system, so it's seamless between the different practitioners. And what looks different is that instead of just being a row of therapy offices, we have a fully equipped medical examining room and medical equipment in the space for the internist to do physical exams, draw blood, take urine samples, whatever. So just to outline for you the range of services, it goes from assessment through IOP and individual and couples therapy and group to psychiatric evaluation, med management. We also, my partner Glenn, offers transcranial magnetic stimulation, which is a treatment for chronic medication-resistant depression. Our most interesting service by far is the outpatient and in-home medical detox, which we have been having a lot of fun with. Fun's a funny word here, but it's been very interesting, and it works better than I think either of us would have thought. So in addition to the mobile medical staff, which are the physicians, and we have a PA that also makes house visits, we have recovery coaches and registered nurses who can stay with the patient 24/7 if needed. It's often not needed, but sometimes it is. Of course, we provide the whole range of pharmacotherapies, and some patients, as you know, chronic alcoholics have some pretty severe liver disease, and while our internists don't attempt to take full responsibility for managing those conditions, they collaborate with the hepatologists and others that the patient may be involved with. So what have we learned thus far? Well, working in the same space clearly promotes, in our experience, closer collaboration both within and across disciplines. Now, we have a number of psychologists and a number of physicians all working in the same place. So it's not just about interdisciplinary collaboration. It's about collaboration between practitioners in the same discipline. And among the staff of clinical psychologists, we have, although everybody would identify themselves as an addiction specialist, they have their own particular areas of expertise, whether it be trauma or DBT or the like. As you might imagine, there are frequent hallway consults. A lot of the collaboration is informal. We don't have to have a lot of meetings, planned, scheduled meetings, because we run into each other all day long. We're able to communicate quite freely. At the end of the day, when everybody's done seeing patients, whether that's 8 or 9 o'clock, we hang around and talk for a while. Certainly, I can tell you it's been very welcome to no longer practice in complete isolation, to be among other practitioners during the course of the day. We've also found that there's enhanced collaboration with outside practitioners. I get to interact with psychologists who send patients for medication. We're not providing any psychological services to their patients, but we do interface in one way or another. And there is an enhanced referral volume and revenues as a result of this. We have facilitated the cross-referrals between us. Can't tell you how many patients come in where their presenting problem is depression and anxiety, and when you do a thorough assessment, the patient's got a history of chronic relapsing alcohol or drug abuse. And vice versa. Many of the patients who come in for substance abuse are not presenting with problems of depression, anxiety, bipolar disorder, or whatever, but in many cases it's appropriately identified and treated. So that's our experience, and I will stop here in the interest of time, and hopefully we can go on. Thank you.
Thank you, Dr. Washton, and happy to bring up Dr. Andrew Weintraub, who's been working and coordinating services at Bellevue in the addiction department for these many years, and looking forward to his presentation.
Thank you, Dr. Druman. Boy, it always sounds funny when you're talking to a microphone, but I suppose it will work. So, start slideshow. Where should I do that? There we go. Great. So it's been a long day. I hope everybody's still hanging in there. And there's been a lot of information to digest. And in graduate school, they taught me that one of the major things that is true about memory is there's such a thing as a recency effect. So as the last person to speak today, I guess maybe I'll be the most memorable, I hope. Anyway, so the title of my talk is Inpatient Mica Therapy, Therapy Outside the Margins. I'd like to explain a little bit about what I mean about that. Inpatient Mica treatment has really begun to change in ways that I'll detail. So much so that the traditional ways of applying or using psychotherapy within that context have been completely revamped. And the challenge is for us to find ways to provide therapy that is meaningful for patients who really do need it. So let's begin this show. So just so that we can all be on the same page, I'm going to show you some statistics that come from the ECA, or the Epidemiological Catchment Area study that was done in 1999. It's about the largest study that we have available, even if it's a little bit old. But 37% of those patients with alcohol disorders have some comorbid psychiatric disorder. 53% of those with other drug disorders have comorbid psychiatric disorder. People with schizophrenia diagnoses were 3 times more likely to misuse alcohol and 6 times more likely to misuse other substances than those without schizophrenia. I'd like to add to this mix that in addition to the traditional psychiatric diagnoses that we see, There have been a whole host of new substance-induced psychiatric disorders that have been showing up, I think, with some virulence throughout the city. And in particular, what I'd like to point out is that K2, which is now pretty widely available, is becoming a major source of psychiatric problems, as we're seeing them in the emergency rooms and the psychiatric units of municipal hospitals. If you go into most any bodega and look up behind the counter, you'll see these nice little packets that say Green Giant and things like that. That is K2. And if you don't know much about K2, K2 is synthetic marijuana, synthetic THC. And somebody's cooked it up in a laboratory specifically to have the psychoactive properties of THC. But for those of you who don't know, when you smoke marijuana, not only are you getting THC, but you're getting another balancing type of cannabinoid that's in marijuana, which is cannabidiol. The two of them tend to be in balance so that it doesn't ordinarily provoke psychiatric problems. Most people do not flip out when they smoke a joint. But when people do smoke THC, they're winding up in emergency rooms with psychoses that take a week, 2, maybe even 3 weeks to resolve. So that's another thing that we're beginning to see quite a bit of. If you know much about city hospitals, you know that the portal is the CPEP, the emergency room. Patients are ordinarily brought there frequently against their will because they're in some distress. They're either suicidal or they're an EDP, which is code word for an emotionally distressed person. So somebody calls the police or EMS and they wind up being taken, often in restraints, to an emergency room and hospitalized involuntarily. From that point, they need to be assigned, they need to be observed. If they're intoxicated, they can wind up being discharged from the emergency room. But if they remain psychotic, they need to be admitted. And their admission is going to be based upon where there's a bed. Now, we at Bellevue have a Mica Unit, which is one of the places that I do work and supervise. And on this Mica Unit, we have I think it's both disparagingly and enviously called a boutique program by other people in the hospital. We have a program that's set up to try to address both the psychiatric as well as the substance-related issues simultaneously. But if a patient winds up with a bed that's available on a different psychiatric unit, that's where they go. So if you look across the different psychiatric units, the patients look identical. They're really not all that different from the Mica Unit compared to the other units in the hospital. But at least on this unit, there should be some sort of coordinated approach to try to deal with the issues. And on the other units, that sadly is frequently lacking. So many of the patients who wind up getting admitted to psychiatry units don't get anything to approach the substance issues beyond something very generically in the realm of relapse prevention. In terms of therapeutic modalities, this is going to be pretty straightforward. It's stuff that you've heard already, but one that I'd like to take a little more than a moment to discuss is the motivational interviewing approach. Depending upon how familiar you are with what MI asks the clinician to do, it's a fairly rigorous program of how to stay neutral. And the question has arisen, can you afford to stay that neutral in working with somebody who you have a very small period of time to work with? And in a setting where groups are primarily the intervention that we use, as opposed to individual therapy, which is a bit more of a scarce commodity, the groups can at least reach out to a lot of people. How do you do motivational interviewing in a group? I don't think Miller really set it up for that to be the way that this kind of treatment is administered. So there's a lot of psychoeducation that goes into that, with an explanation of what motivation is, what a decisional balance is, how to start thinking about this, and there needs to be, at least from my perspective, a certain amount of inspirational thrust behind the way these groups are conducted compared to what you might do if you had the advantage of a little bit more of a leisurely individual approach to work with somebody on their motivational issues. Relapse prevention, of course, is a signal aspect of what we do. CBT, and one thing that's been echoed over and over and over again today is the therapeutic relationship, because none of these therapeutic modalities will be worth anything in the absence of a good working therapeutic relationship. And it can be very challenging to try to develop that kind of relationship quickly with a patient who's psychotic or severely depressed, or who has significant negative symptoms and has difficulty with relationships to begin with. So this is a major obstacle in working in this kind of setting. In terms of the economics, I'm not sure how familiar you are with the current Medicaid situation, but if a patient stays in the hospital for more than 13 days, the rate of reimbursement for the hospital begins to decline successively, so that on the 14th day the hospital gets less money. Where do you think the hospital administrators put their emphasis at this point? We have weekly length of stay meetings where the patients are reviewed in order to see whether or not do they really need to be in the hospital at this point. And then once the patients are discharged, if they're readmitted, within 30 days, there's another financial penalty that the hospital has to pay. So they get you on both ends. You can't stay too long in order to really be stabilized properly. And if you happen to come back, well, then that's bad news for the hospital. So this is the climate that we're working in, and everybody is feeling the pressure for that. There was an article, and let me get you the actual website here. It's called the Mental Illness Policy Organization, mentalillnesspolicy.org. It's called Inpatient Psychiatric Care in the 21st Century, The Need for Reform by Glick, Sharfstein, and Schwartz. If you go to that website, it's pretty easily found. And they coined the term micro-hospitalization. And the basic idea in psychiatric hospitalization at this point is that what you need to do is to make sure that there's a stabilization in the crisis and the patient is safe, and once you've hit those criteria, the patient's out. Okay? So the definition of what safety is all about has become a very elusive kind of thing. Safety can mean, yeah, I don't think I want to kill myself anymore. Okay, we'll see you. That's nice. It's been great knowing you here. Needless to say, that has not really resulted in patients being as stabilized as they could or should be. And I think it's one of the major problems that we're dealing with in this world, in the world of inpatient psychiatry. The obstacles to treatment are pretty big in psychiatry, inpatient psychiatry in general, but within this climate of micro-hospitalizations, they become even that much more of an issue. Number one, they're the internal or within the patient issues. When somebody's actively psychotic, how available are they for any kind of therapeutic intervention? If all they want to do is stay in bed because they're too depressed and really won't engage in a conversation, if they're experiencing auditory hallucinations, if they're actively delusional, their availability for psychotherapy might not be all that great. Oops. I got to go forward here. I don't know how I got back there, but okay. Secondly, when patients come in, one of the things that happens, especially if they're very agitated, is they get sedated a lot. Patient who comes in who's manic, doesn't want to take their mood-stabilizing medications, often winds up having what they call CMTs, crisis management teams, where a bunch of very brawny young guys come around, followed by a nurse with a needle, and they get injected with antipsychotics, which puts them to sleep, but it doesn't do very much for their mania, because it's an antipsychotic, not an anti-manic. So they may not be awake to be there for individual or group therapy. And a lot of the patients are there involuntarily, and their motivation to engage in treatment is compromised to begin with. So that's yet another obstacle that we're dealing with. The external obstacles, insurance coverage. Where are we going to send these people? Now, yes, there are rehabs, and a lot of rehabs accept Medicaid, but if you're talking about some of the more higher-priced private rehabs, I've heard that some insurance policies have $25,000 deductibles for patients in terms of their substance abuse treatment. I don't know how this shakes out in terms of the parity issue, but it's one of the things that we contend with, and I'm sure that others contend with, in figuring out where we're going to send people for aftercare. And then, once we do get people out from this very hot experience of being in inpatient psychiatry, they go right back to the situation that they were in before. They're sent back to the same shelter. That's a New York City HRA requirement. And there's people right next to them who are drunk or high. The dealers are everywhere. All of the triggers that we've been talking to them about in relapse prevention are abundantly available. So it's like swimming against the tide, and it's a really very big problem. Which brings us to the issue of therapy outside the margins. How do you conduct therapy within this environment in order to try to make a difference? First of all, when the patient is available, that's when you need to be there as their therapist. When they stop being sedated, when they're not hearing voices sufficiently to be so distracted that they can't pay attention, when their depression has begun to lift sufficiently that they can engage in some sort of therapeutic dialogue, that's when the intervention does need to happen. And it's often a very, very narrow window of opportunity. The frequency of interventions, if you've got them for a very short period of time, well, maybe you need to see them once or twice a day. You can't afford to have this kind of setup where you're seeing them, once a week, that's nice. But it doesn't work. You need to see them as much as you can possibly see them in order to try to get the maximal therapeutic benefit. If you've ever been on an inpatient psychiatric unit, you know that confidentiality and privacy is something that's really not available. There are big open spaces. There are rooms with windows so that you can be observed. There's no private consultation room. And frequently patients are apathetic or they're just restless, and all they want to do is pace the hallway. Well, that's where therapy happens. You're taking a walk down the hallway with them and doing therapy at the same time. So that's yet another margin that we're dealing with that we need to deal with outside of the way therapy is traditionally conducted. When the patient, how the patient, where the patient will accept it. And you've got to be sensitive to what the patient tells you in terms of their willingness to accept what therapy you're offering, including, I only want to talk to you for 5 minutes today. Well, 5 minutes is better than no minutes. So you take it, and that's where you make your difference. And finally, and this is I think the most important point, is that you've got to recalibrate your goals in the context of the resources that you have. You're not going to achieve abstinence. You're not going to achieve some sort of personality reorganization. You're not looking to do that. If all that you're really going to be able to do is to get the patient to, as I think somebody earlier, I forget which presentation said, to stop and make their decision of whether or not to use a conscious choice, rather than simply something that, well, they're going to do it because that's what they do. But do I really want to do this? That, I think, can be the most important therapeutic goal that we can set for patients. So that's pretty much the message that I wanted to deliver today, and I guess we're going to go to some sort of panel discussion at this point. Anyway, thank you.